Peds Pod.
Hello and welcome back to BNSSG Peds Pod. I'm Ruth Bowen. I'm a Bristol GP working for the BNSSG Training Hub, bringing baby, child and young person education to primary care clinicians. Today I'm joined by Katy, Pike and Deborah Marriage, who some of you may remember from a previous podcast episode about asthma a little over a year ago, but have very kindly come back to speak to us again because there has been such a massive overhaul of the guidelines. I think we in primary care need a little bit of help trying to figure our way through it. So thanks so much for joining us, both of you. For anybody who's not heard the previous episode, do you mind introducing yourself?
I'm Deb Marriage. I'm consultant nurse for Allergy and Asthma and I work at the Children's Hospital alongside Katy.
I'm Katy Pike. I'm a consultant respiratory paediatrician at the Children's Hospital. And Deb is being modest and not mentioning that we're also at ICB Leeds for asthma.
Fantastic. Well, thanks for bringing your expertise to this conversation. It is massive news that NICE, BTS and SIGN have all managed to agree one combined new asthma guideline, which does have some quite big changes. Can you tell us a little bit about the headlines with this? What are the biggest changes with the new guideline and do you have any understanding as to why the guidelines have changed?
I think it was very difficult for people to follow discrete guidelines previously because the guidance wasn't the same on both guidelines. So it's great that they brought it all together into one guideline. One of the key take-home messages is the use of salbutamol. So no one is to be prescribed salbutamol by itself anymore, which is great news, I think, moving towards working in line with the GINA guidance. Other key messages are that there are now 2 pathways that we can follow for children in terms of managing their asthma and preventers. So we can either go down the MART pathway or we can go down conventional treatment pathways. Other things to think about are the fact that anti-leukotriene medication is now under closer scrutiny than previously. And ideally we should be diagnosing people before we treat them, and now hopefully we can diagnose them with just one diagnostic test, which may make people's lives a little bit easier.
Fantastic, and a lot more pragmatic as well, I think, in primary care. And what are the advantages of MARTs?
It takes away the ability for somebody to overuse their salbutamol inhaler, which is a big problem in primary care. That's probably the main advantage, but it also means that if you have poor control, then you're taking extra steroid and treating the inflammation. So you're not just relieving your symptoms, you're treating them more effectively as well.
And as is the usual tradition, I've got some cases just to help us understand the guideline changes as well. So our first case, parents present with 7-year-old Ellie with a dry nocturnal cough for several months, now present most nights. On questioning, she does report a tight chest on exertion and wheeze when she has coughs or colds, or stays at her grand's old dusty house. She had a history of several episodes of viral-induced wheeze as a preschooler and mild eczema. Mum had asthma as a child, and both parents are prone to hay fever. They have a cat, but there are no smokers in the household. So, Deb, this sounds like a pretty convincing history for asthma. If we follow the new guidelines, do we need objective testing, or can we just start treatment?
Ideally, if you can perform objective testing at the same visit or within a couple of days, then that's fine. And ideally, you'd have that testing done before you treat her. If you're going to have to wait a long period of time for the pheno test to be done, then yes, you should start treating her straight away.
And what test should we arrange in primary care?
Ideally, a pheno test would be the first test that we'd look at, and hopefully the only test, if we get a positive result.
The dreaded question then, if we did start an ICS and then they came back for pheno, would we need to stop the ICS before we did the pheno test in order for that to be accurate?
The guidance is quite unclear on this. Personally, I would recommend that it's stopped for a few days. So we know that your pheno will start to rise 5 to 10 days after you stop treatment, so I probably would recommend stopping it for a week or so.
Is there a little bit of leeway with that in terms of how symptomatic they are and whether it's safe to do that?
So I think we need to bear in mind that a guideline essentially is just a guideline. It would be very helpful to obtain an objective test. If the moment arises when they're reasonably well controlled, you maybe can stop their medication for a few days, then that would be brilliant. But obviously, if they're really poorly controlled, then we're not going to do that.
Brilliant, thank you. And can you talk us through the lateral objective test? So if pheno is normal, but we've still got a strong clinical suspicion, do we then refer for spirometry or try peak flow variability in primary care?
The algorithm suggests that you would do spirometry first, but that isn't always possible in primary care. So ideally you'd do spirometry with reversibility. If you can't do that, then you could do a 2-week peak flow diary and look for variability. That would be the next step.
So if Ellie's pheno, just to be clear, is normal, but I really think that she's got asthma from this very clear history, you would then suggest that I go to the next step and try spirometry?
Yeah.
Thanks. Luckily, pheno is actually raised at 42. How would you want the clinician to manage Ellie?
If we haven't already started treatment, then we need to do that. So we would start on paediatric low-dose Plenol 2 puffs twice a day, 100 strength, and see how that goes down.
And then what should we try next?
If you find that that isn't helpful, you need to check all the things that you will have done before you started it, so adherence, inhaler technique, that kind of stuff. If that doesn't work, then either consider adding in Montelukast, or you could look at going down the MART pathway if she can manage the MART inhaler, if she can use a dry powder inhaler.
So is that what they mean by use a MART if they're able? So it's can they manage the dry powder inhaler? Is that the question?
That's right, because lots of small children or young children really get confused between inhalers. They're used to blowing in and out of a spacer, so they may blow into a turbohaler, or they maybe just can't suck in hard enough. There are lots of trainer devices that you can use, the whistles, etc. And if you're really not confident that someone can reliably use it, then I wouldn't go down that route.
Okay. And using a MART is being recommended for these 5 to 11-year-olds, but it's off licence until the age of 12, is that right?
It is off licence as the MART regime. The medication itself is licensed, it's just the way it's been used is not. There is an alternative that is licensed, so we don't have a lot of choice, but it's recommended by the guidelines.
Okay. And if Ellie can't tolerate a MART, what would be the alternative for her? Can you talk us through that part?
Yeah, so again, you can think about the Montelukast option, or you can go down the conventional treatment, so a ICS-LABA combination, essentially.
Brilliant, thanks. Can I ask why Montelukast is added earlier in these new guidelines for the SAGRIS group compared to the previous guidelines? Do you have any idea why that is?
That's a good question, and no. I think we'd need to be on the panel to understand that. But NICE does look at efficacy and cost, so it's possible that it may be cost-sparing to use Montelukast first.
And should we have any concerns about the potential psychiatric side effects of Montelukast?
Yeah, I think we should. When we're starting a patient on it, we always need to talk through what those potential side effects might be. So if night terrors are quite common, nightmares, psychiatric and behavioural changes, mood changes, etc. And there was, in November 2024, an MHRA safety advice document on the risk of neuropsychiatric effects. So it is important that we do talk those through with people. Also, some people have read about it in The Guardian or The Times and have it on their radar and know that they don't want to use it in their child.
Thank you. Coming on to our second case. 4-year-old Archie's been treated for viral-induced wheeze on 5 previous occasions, including 1 admission from A&E. Parents have started to notice a wheeze when he's running, even when he's well. There is a strong atopic family history, and Mum has given him his brother's salbutamol on a couple of occasions with good effect. Parents think he has asthma and wonder if it's time to start treatment. Katy, taking into consideration the new guidelines, what would you want the primary care clinician to do?
Archie's going to be a good case study for thinking about what we're doing for the under 5s. He is a child that's already got some risk factors that are increasing our thoughts that he might have asthma. He will have this new category assigned to him, I think, of suspected asthma, because we've got all these suspicions based on his own symptoms, his family background, and actually even response to treatment in a way, because presumably his mum's giving him the salbutamol because she recognises the symptoms from the elder brother, but she probably wouldn't continue doing it if she didn't find that there was a benefit from it. But he's going to be suspected until such point as we can get the definitive test that Deb has already mentioned for the older children. Our thinking around this group is going to evolve a little bit over time, because there will be children where we genuinely suspect asthma, and there'll be other children who possibly have a form of wheezing that's going to resolve when they're less exposed to viruses, a bit older and a bit bigger. Often you can make a good guess, and I usually am quite transparent with parents and patients and say, we know that very many children wheeze under 5. 60% will have 1 episode or more up until their 5th or 6th birthday. But we know that not all of those children go on and have asthma, and it can be quite difficult to exactly predict, but you can have a hunch. And so for this child, my hunch would be that I really do suspect asthma and he could go on to have asthma. Apart from that, his symptoms at the moment, to my mind, are significant enough, impacting on his life and presenting a sufficient risk that he should have a treatment. I think the new asthma guidelines are designed for asthma. They're not designed for preschool wheeze. And I would say watch this space to some extent, because for a condition that is intermittent, when the viruses come and then the viruses go away again, I don't think we have a brilliant treatment as yet. And watching the rest of the guideline go very much more towards treating symptoms when they're there, even though we've told patients for years not to do that, it does sound like there is some benefit in going with the natural tendency to take a treatment when you're unwell. So I suspect there will be more intermittent treatments potentially for younger children as time moves on. But presently we don't have evidence for that. So it's a question of when you've got a significant suspicion in under 5, the treatment that we'd offer would be an inhaled corticosteroid at a low dose. Because we can't back it up with those objective tests, we would suggest an 8 to 12 week trial. And then at the end of that, considering how high was our suspicion at the outset that this was asthma, what's been the progress in those 3 months, and if things have completely resolved and there's any suspicion that you think, I'm not sure I want to commit this child to a steroid for the rest of their life or for several months or years, you can actually put a halt to that treatment and probably halt for about, again, an equal period, 3 months, to see have the symptoms come back in that time. And another aspect of the new guideline, actually, which is of interest, and you have asked me, what do I want the primary care clinician to do? So I'll say what I want and not what I don't want. But the new guideline does actually say that any child admitted under 5 with wheeze should be referred to paediatrics, which I really don't know quite where the evidence or suggestion for that lies. But the numbers of people that would be coming into 5 consultant paediatric respiratory consultants in the southwest would be gigantic. But this particular case, he's been admitted from the emergency department, so he would fall under that part of the guideline. I don't think it's even prefaced with consider in this situation, but I would urge people to consider. And I think the thinking behind this is that the very young children, because wheezing is so common, there will be people wheezing for reasons other than asthma. And so if there's any other symptoms that are slightly concerning, so weight loss or a wet cough, anything that might be a diagnosis other than asthma, that might be when it's worth having them referred on for another look. But it's certainly not every child that's admitted with a wheezing episode, I would say.
That's a really good point. I must admit I'd actually not noticed that change in the guidelines, so thanks for highlighting that.
So I'd noticed it because I knew it was going to affect me.
That's fair enough. And that does make it really clear. I found that quite confusing with the trying the ICS and then taking them off, and if it's got worse, then restarting it. So that's a very pragmatic, taking into consideration the clinical context way of looking at it. And then when he turns 5, if we think there's an ongoing need for the inhalers, do we then need to stop and do those objective tests? And do we need to change his management at all?
The age cutoff is putting an artificial lens on something that's a natural evolution of children and symptoms over time. But it would be nice to have some objective testing because this is a young person that's going to grow up and there'll be occupational considerations. Certain occupations are closed to somebody with a diagnosis of asthma. So you don't want to be on treatments that you don't need, and we don't want to be paying for treatments that people don't need. It's always worth keeping any diagnosis under review. But the key thing about the age here is just the ability to manage objective testing. And I would say you might get some peak flow readings below 5 if you were really interested and you had a motivated family. For spirometry in the community, even 5 might be a little bit young, and you might end up with quite difficult to interpret results because in order to look at reversibility, you need to have a really nice baseline that's reproducible to make your reversibility meaningful. Lots of young children seem to empty their lungs really quickly. So they basically do a peak flow manoeuvre rather than a spirometry manoeuvre. FEV1 often is quite high. You don't see that scooping that you do on an older child. So probably their best option is pheno, which again can be quite tricky. It's more difficult, I think, don't you find, Deb, for the children to blow out in a consistent way. But I think they should manage that around 6 in the community. There's no rush to do that, but it can be helpful.
I'm interested as well to you saying that it's more about them managing the objective test, because I had perhaps wrongly assumed that it was also partly due to the fact that at that age they might have recurrent viral-induced wheeze, and therefore you'd be calling something asthma when actually it's just recurrent viral-induced wheeze and the timing that you've done the test.
That's true. And I think we still don't know the answer to this, because I can remember asking other colleagues when I was training, well, how do I know someone that is wheezing when they're 3 and then they go on to have asthma, is what they had when they were 3 the same asthma that they've always had, or did they have something different then? And I think over time my experience has been for the people that have asthma, they've always had asthma. It's just that little bit more difficult to pick the asthma because you wheeze with viruses when you've got asthma, right? So it's not exclusive to viral-induced wheeze and preschool wheeze being a different condition. I think you're right. I think it is both. With a view to reviewing the diagnosis, that's something that is ongoing throughout the life course. So you probably would always keep this under review, and things that would alert you to that would be somebody that is dutifully picking up their repeat prescriptions, but you never have heard that they've ever had an attack or an exacerbation. And it can be difficult to know how much salbutamol use is going on unless you ask. So again, on repeat prescriptions, if the salbutamol is given quite regularly alongside each preventer, you probably wouldn't get a flavour of who's struggling and who isn't. So I think it is useful. Though I don't like the arbitrary age cut-offs, maybe age 5 would be a really good time to put in people's minds to think, do we need to check in with this person? Have they still got an active diagnosis?
Hopefully they're having their annual asthma reviews anyway, and we're picking up if they are just never having exacerbations, that perhaps it's time to step down on the algorithm.
Yeah, exactly that.
And would you want to change his management at that point? So we've put him on an ICS. He is now 5, so if we wanted to, we could go down the new guidelines for the 5 to 11s. Would you do that?
Well, I suppose the new guideline is saying you will change your management if you're uncontrolled. So if he's doing fine at 5 on what he was started on when he was 4, for example, there isn't a big driver to change. And indeed, there could be cost and other implications of changing. And then a failed change is going to lessen confidence in the medication. It's going to end up with a complicated repeat prescription with all sorts of inhalers being dispensed at different times. So I don't think there's any hurry to change, but it does open up more options.
Brilliant, thanks. So coming on to our third case, 14-year-old Toby presents for his annual asthma review. He's on Seretide 150, 1 puff twice a day, and salbutamol. He reports a nocturnal cough several nights per week and uses a salbutamol due to daytime wheeze about 3 to 4 times every week. Deb, how would you want the primary care clinician to manage Toby?
Well, I think, first of all, I'd want them to check he was picking up his medication. I think that's really important. He may be that he's picking up lots of salbutamol and he's had 3 Seretide AccuHalers in the last year. The other thing to think about would be his inhaler technique. Can he actually use an AccuHaler in a dry powder device? Most 14-year-olds should be able to, but they certainly all can't. Or is he using it incorrectly, etc.? That's quite important. Is he using his salbutamol out of habit would be another thing to think about. Or is he actually symptomatic when he's using it?
Brilliant. And if you were happy from that history that actually he did genuinely have good technique and he did genuinely have that need for the salbutamol, would you want to change anything about his regime?
Yeah, there are lots of options for change here. It would also be useful to have objective testing as well, because that would give you the evidence that he's not well controlled. So he would be an ideal person to put onto a MART regimen, because we want to take that salbutamol away from him and stop him from overusing it. Also means that he would have to have his steroid. You can't separate them, so that would be important. That would be my next step.
And what step of the MART would you switch him across to? Do we start at the bottom, or is there a way of titrating based on what they're taking already as to how strong an ICS they should have in that MART?
You can look for equivalents in their steroid dose, but essentially you would titrate it according to need. I would give him a 200 strength inhaler, and we'd talk through how many doses he's able to use, when he needs them acutely, whether he's using them as a reliever, and what his preventer doses are.
Thanks. And should we be switching all our patients across to the new regimes? I think Katie's slightly answered this in the last case, but what do you think?
I agree with Katie, actually. If someone is really well controlled, why would you want to fiddle with that? I guess there is the green impact to think about, and that's obviously really important. But if someone's well controlled, I probably wouldn't unsettle them. I would leave them where they are. I think there are other things you can be focusing on rather than swapping people for the sake of it.
And the guidelines are quite clear about that. I was pleased to see that it is actually quite pragmatic in
Yes, no, that's
reality.
really good news, isn't it? Otherwise it would be a real worry if everyone just started swapping their patients, especially if they weren't seeing them.
And can you help us at all with the dosing of the new MART regimes, or where we can find these?
So in terms of dosages for MART, there is a link within the new guideline, which within the pharmacology section, which will take you to the ICS equivalent doses. If you want a simple guide, for 12 and above, if you're looking at air therapy, then we're looking at a 206 Symbicort, 1 puff as you need it. You can't have more than 6 puffs in any one go, and ideally no more than 8 in a day, and certainly not more than 12 in a day without being seen. If you're looking at MART, then low dose MART, again, it's all with a 206 inhaler, so either 1 or 2 puffs, depending on whether you're using 1 puff at a time or 2. So you could have 1 puff twice a day or 2 puffs once a day. Or if you go for the moderate dose MART, then that would be 2 puffs twice a day of the 200 strength. And again, for all of the regimens, it's the same guidance on the 6, 8 and 12 puffs.
And then would I be right in understanding that then for the 5 to 11 years, you could basically do the same thing, but we don't do the air step. We just do paediatric low dose MART and paediatric moderate dose MART, which basically means they use the 106
That's
rather
correct.
than the 206,
Yes.
but otherwise it's the same regime.
Yeah, the regime is the same.
So Symbicort is a good option. We can also use Fobumix, so that's also licensed from 12 and up, but
It is.
But Foster and Duoresp are only from 18 and up. Is
That's
that right?
Yeah.
Brilliant. 2 months later, Dad brings Toby to a duty appointment with a 2-day history of a wet cough, coryza and initial fever which is now settled. He's short of breath and wheezy on exertion. Toby had been complying well with his twice-daily maintenance MART doses and was having around an additional 5 PRN doses per week since he was seen, but has increased to 3 to 4 times daily over the last 2 days. Toby's marginally tachypneic, but otherwise observations are normal, including SATs of 98%. He's able to speak in full sentences with ease. There's scattered wheeze throughout his chest despite using his MART 4 hours prior, but there is decent air entry throughout. What are your initial thoughts here, Katy?
Well, it sounds like Toby's having a bit of an exacerbation, possibly triggered by a respiratory infection of some type. And he's doing the right thing. He's following his MART regimen, which is probably in his plan. So you can check with him that he's got a plan. You can maybe think about observing another reliever dose of his inhaler because he's still wheezy. And that would just give you a little insight into how he's taking it. Is he taking it appropriately? And is he getting some relief from it? Because you won't be putting him over the 6 within a short period, which I think can be difficult to know what a short period means, but I've seen it written it's 1 to 2 hours. You're outside of that window, so he can have more, and he's not got up to 12. It might be that you think, does he need some steroids? You can use his current status and his past history to guide you on that. A history of severe attacks might lower your threshold, for example.
Thank you. You mentioned using the reliever MART. Is there still a role for salbutamol at all? Because that is obviously still a long-acting beta agonist that you've got in the MART. Does salbutamol still have a role?
I think it is going to continue to be used within the hospital setting. Now, that might come under challenge. Asthma care is evolving. We don't know what future studies and investigations will throw up. But the move to MART can be interpreted very simply as salbutamol's dangerous, which is probably overstating the concerns about salbutamol. Salbutamol overuse is dangerous. And it's dangerous because you don't have any anti-inflammatory treatment from salbutamol. If you've had a fair amount of inhaled MART, which will give you steroid, it will give you bronchodilator, if your airways are so bronchoconstricted that that medication is not effective, you possibly will need some salbutamol. Now, that might not be inhaled salbutamol, it might be intravenous salbutamol, it might be some other intravenous bronchodilator. But those medications are obviously not combined medications, but in context, they're combined with steroids as part of that emergency management. It's likely, until these guidelines have bedded in and become part of everybody's lived experience, that when patients visit hospital and emergency departments, they will most likely be treated by salbutamol either as nebulizers and possibly as inhalers. And it may well be exactly the right thing to do, because definitely we want an acute bronchodilator. But we need to be careful with our messaging around that in all healthcare contexts, because if we're giving a very simple message to patients that this is the new treatment and salbutamol's useless, and then a patient is given salbutamol in hospital, it's going to be confusing. We have to parcel that as emergency treatment. This is now an emergency. That might actually be a really beneficial message for patients, because previously, effectively, they were giving at home what they were going to be given in hospital. And there were a number of people that would tell us that in clinic, and they'd say, well, I'm not going to hospital because I can do that at home. And I know when I went to hospital last time, they put my child on 10+4 hourly. So the next time they get a sniffle, I'm going to start on 10+4 hourly. And that was kind of how we got in this mess in the first place. With the MART, many informed parents and patients might have some concerns about taking a lot of steroid, which in a way is a good thing because it means they'll get to their 12 and they'll seek help, I'm hoping.
You're saying about the parents coming home and then wanting to just use salbutamol. I do have a very standard diagram that I draw that's just a cross-section of an airway, basically showing the bronchoconstriction and the inflammation of the mucosal membrane, and very simply saying this is what the SABA does, it only changes the bronchoconstriction. But actually, if you've got all this inflammation going on and you haven't been using an ICS already, we can only do so much with that one method of tackling it rather than two.
Yeah. And it might be that the salbutamol in hospital is going to work an awful lot better now, because patients haven't been sort of hammered with salbutamol up until that point. So hopefully the steroid will increase the receptiveness to the bronchodilator and the receptors won't have downregulated. Maybe it's a brave new world.
Maybe. Just thinking about how we alter our asthma plans so that we're advising when patients need hospital, if we're not counting the salbutamol puffs, does that very much relate back to what you were saying about the not using more than 6 puffs in about 1 to 2 hours? maximum 8 per day, but actually pushing that for a limited period up to 12 per day, and that's the point they go to hospital. So that kind of equates to our 10 puffs 4 hourly.
Definitely. So we've got a MART asthma plan Deb and I have created and put it on Remedy. It does give those elements of advice.
Perfect. Again, relating to this, should our management of life-threatening asthma change, or do we still revert back in practice when we've got those really acutely unwell children to giving them oxygen, salbutamol nebs and ipratropium nebs? Is that reflected at all in these guidelines? It feels like these guidelines are very much about chronic asthma rather than those real acute cases.
Yeah, the introduction said this only supersedes certain elements of the previous guidelines. But when you go to the BTS website, it is actually really hard to find the 2019 BTS guideline now, which is a bit of a shame in a way because it's got lots of stuff about occupational asthma in pregnancy. It was over 100 pages long, but some of it I think will be lost. And the acute management is still in that guideline. It's not really covered in this new guideline. That for now is going to remain the same.
And what about our management of acute viral-induced wheeze? Again, this guideline doesn't really touch on that. Should that remain the same?
So essentially, the management of wheeze is just shifting away from giving lots of prednisolone in primary care or Dex or whatever steroid you're using. So essentially, use the salbutamol as you need to, and then if anyone needs oral steroids, generally the best place to divert them to is the hospital for review.
Thank you. Do you guys have any take-home messages for us?
I think it's quite reassuring that we can hopefully now diagnose asthma with one objective test rather than 2. Hopefully that will make services run much more smoothly. And of course, the most important message, as we mentioned before, is tackling the salbutamol overuse problem. It's really important that we do that. So this guideline does go a long way towards addressing that. Obviously, there's lots of work yet to be done in that area, but it's very positive.
The guideline's going to take us a little while to feel confident with it, but we should engage with it and not follow it slavishly and give some thought to those little sentences that tend to precede the directions. So before you go down any of the pathways or follow any of the directions, for example, a diagnosis, apply the test to people that you already have a suspicion might have asthma. Because I think you could read this guideline of do pheno on everyone that says they've got a cough, for example. And then in terms of treating very young children with inhaled steroids, there is a consideration about how severe and how frequent the symptoms are, rather than just anybody under 5 should automatically be committed to 12 weeks of corticosteroid.
Thank you. For me, some of the main take-home messages are the objective testing, the dosing of Symbicort that you use as a MART regime. Really good to get my head around that a little bit more because I found that really confusing. And understanding as well that the MART is a dry powder device and that's why children might actually struggle with it. That explains the phrasing of if they can tolerate it. So that's really helpful to understand. And are there any particularly good resources that either of you have come across that might help us to get our heads around the new guidelines or understand the rationale?
The algorithms are quite helpful, the visual diagrams in the guideline itself.
I agree, I found them very helpful.
Yeah.
Actually, and just being a nice brief summary.
That's how I found them too.
Perfect. Under this podcast, I will attach a link to the new guidelines, which includes those algorithms and the lovely MART regime personalised asthma action plans you've made that are on Remedy.
Another resource is from the Primary Care Respiratory Society. There's a little pamphlet which shows you how to measure variability in peak flow. Now that the stipulation is moving away from having to have laboratory level lung function with spirometry and pheno necessarily, because you can use peak flow, gives a bit of guidance on how to work out the numbers to make a decision on that.
That sounds really useful. Thank you. Thanks so much for joining us.
Thank you.
The contents of these podcasts are for educational purposes, aimed at primary care healthcare professionals only. They do not substitute professional medical advice or consultations with healthcare professionals. Information presented is the opinion of the healthcare professional interviewed, based on their interpretation of best practice and guidelines at the time of the interview. It is the listener's responsibility to compare information given with up-to-date national and local guidelines. The BNSSG Training Hub, Ruth Bowen, and interviewees are not liable for any clinical decisions made as a result of this podcast.